I'm going to go ahead and introduce Mr. Mitchell Rothholz, who is here from the American Pharmacies Association. He serves as their Chief Strategy Officer and also a member of NVAC, who is going to be speaking on the role of retail pharmacies and pharmacists in vaccine delivery in the United States. So we'll have you take it away. Oh, one thing, before I get started, Gene Smith also asked me just to mention, looking up at the screen here and making sure that you register for the meetings in a timely way. The website for the October meeting is now active. We have an absolute deadline for U.S. citizens of October 7th in anticipation of the October 23rd meeting. And for non-U.S. citizens, the registration has to be done by September 30th. So just, again, the website is open. And I'm also sure that if you register multiple times, like sometimes I do because I forget I've registered, that's not a problem. We'll move ahead with the next session.
Thank you, Dr. Tempte, and thank you for the invitation to speak to you this morning. I'm going to try to get through a number of slides to give you an overview of the pharmacist's role in immunizations. On this slide lists the scope of our discussion, but I do offer that if you have questions that we cannot answer during the question and answer session, please feel free to contact me for further discussions. I'm more than glad to talk about issues with any of you in the room. Give you a little setting the stage. The American Pharmacists Association is focused on improving medication use, advancing patient care, and meeting the public health needs of our nation. Through the last 20-plus years of activities, we have been able to support pharmacists in the area of advocacy and policy, education, publications, as well as networking. And many of you in this room have collaborated with us over those years to get us to this point of where we are as a profession. Give you a little historic perspective. Back in 1993, in a meeting of our then CEO with Secretary Donna Shalala, she asked APHA, how can you help us increase the immunization rates for children at that time, but over a period of time that also moved into the adult area as well. And so we took that challenge and started to develop an active program that's been in existence now for about 20-plus years. And I'll show you some historical things where actually pharmacists have been involved in immunizations even before that and working with public health in different ways. But we actually took it and incorporated that within our strategic focus as a profession and organization. In 1995, HCFA then, now it's CMS, recognized pharmacists as a provider. That addressed one of the barriers that we were facing as we were trying to put in place these services. And in 1996, we piloted our first national training program that has now trained more than 200,000 pharmacists in immunizations. It's what we call a certificate training program. It's a 20-hour program that's based on the guidelines that are in existence, as well as best practices that we have gathered over the years. This has become the gold standard for the profession. It has been reviewed by folks in public health, CDC, medicine, nursing, other health professions, and other stakeholders, and all have commented that they recognize its quality and content. And early on, we committed to educating pharmacists across the lifespan. It was our belief that pharmacists needed to be a knowledgeable resource for the public, and in doing so, they needed to understand, even if they were not going to administer pediatric vaccinations, they needed to understand the nuances of the pediatric schedule so that they could help a caregiver sort through that schedule and answer questions and be a resource for public health when there's myths and misinformation that is out there. The pharmacists are an extension of the public health department and the immunization community of getting those messages out. And then in 1999, we began licensing the programs to schools of pharmacy, state associations, and pharmacy corporations, again, to get that reach. We knew we had to get a critical mass of individuals trained. This graph here gives you a perspective of how long we've been doing this and where we've come. You can see from the slide, going back to 1996, even before then, we had about nine states that had authority already, but they never used it. So then starting in 1996, where we started to do some concerted efforts in this area, we started seeing that number grow to where we are today, where all 52 states and territories authorize pharmacists to administer influenza vaccinations. And then you can see the growth also in the number of pharmacists who have received training in immunizations. In 1996, the APHA House of Delegates adopted a policy that called on pharmacists to take on all or at least one of the three roles. First, being an advocator for immunizations. And what that entails is educating the public, motivating patients about the importance of immunizations. Second is to serve as a facilitator, to use their practices as an extension of the public health and the immunization community, to host other healthcare practitioners to increase access, increase information to the public. And third, in the states that allow pharmacists to immunize, to get the training and to begin to offer those services in their practice. Pharmacy has a unique contribution to make to the immunization initiative. Access and proximity and extended hours are something that we feel that we bring to the picture, especially when other practices are closed. And where this really came to light is under the 2009 H1N1, where we were getting close to the holiday season, and clinics and other practices and public health departments were starting to close down for the holidays. CDC reached out to the pharmacy community and asked, could you help us continue to maintain access to the public during that time? And pharmacy stepped up to the plate and worked with CDC to continue to provide access to those vaccinations. Studies have been shown over the years that the equivalent of the U.S. population enters a pharmacy each week. Again, it's not the same patient, it's multiple patients, but again, it's that access point. It's where does the public go that we can help deliver messages, and we'll show you some examples of some of those abilities that pharmacy has in that area. We can identify high-risk patients. We have a public trust. We can disseminate information and messages. We do, and I want to stress that we do follow nationally adopted guidelines, and we advocate that in everything that we do. That's what we train our pharmacists to do, and we continually remind them about what those guidelines say. We can also support completion of multi-dose vaccines, and I'll show you an example of how we think we could help the public health community meet those targets. And then we're knowledgeable about vaccine resources, and we'll show you how we educate pharmacists in that area, and also the ability to handle storage. This little factoid slide is literally a synopsis, and then we'll delve into some of these boxes further on. We talked about the number of pharmacists who have been trained to immunize. We talked about the number of states. And I'm going to focus a little in this presentation on the nuances of the state, because when you see one state, you've seen one state. That's what the challenge for us is in trying to keep track of what's going on in authority for pharmacists, what vaccines they can provide, what's the age limit. And so it's a challenge for us to work through. We talk about training. One of the key things that the public health community has started to recognize and tap into is the reach to the community that pharmacies have in terms of educating the public about the importance of vaccinations. And we actually did a snapshot of looking at what our members were doing in this area, and we estimated that about $40 million were spent in the 2010-2011 influenza season to educate and market to the patients, the public, about the importance of influenza vaccination. We can also target patients who are in need of vaccinations based on age and medications, and we've got systems in place where pharmacists are doing that today. Majority of almost all the pharmacies are computerized, and so we can tap into those systems. But we'll also share with you in this presentation some of the challenges that pharmacy has in terms of getting connected to some of the electronic health systems. In 2009 H1N1, we worked with the public health community. We worked with ASTO, NACCHO, and CDC to talk about how can we improve the relationship between public health and the pharmacy community, and how can we tap into that resource, again, to increase the access to important vaccinations. And we actually published a framework for public health departments on how do you build that relationship. How do you work with the pharmacy? How does the pharmacy work with public health? Again, to meet those goals that we've set up for ourselves as a nation. And they've recognized in the report the uniqueness of that access of the pharmacy. The convenience, the accessibility, the extended hours are all attributes that pharmacy brings to the table. Ultimately, our goal, And this is something that we have been advocating for, and the summit has been working on, trying to build an immunization neighborhood. And the way it has been couched is the immunization neighborhood is a collaboration, coordination, and communication among immunization stakeholders who are dedicated to meeting the immunization needs of the patient and protecting the community from vaccine-preventable diseases. That's what we as a profession have embraced as a focus of why we're doing what we are in the immunization area, and how we are partnering with many around this room, as well as many of the professions and stakeholders in immunizations to achieve this vision. In order for us to meet this immunization neighborhood goal, we've got to address several things as healthcare providers. This is not just limited to the pharmacy profession, but this is all of us who have that same common goal. We need to look at increasing access points. We need to look at the communication and education with our members, with our providers, as well as with the patients. Documentation and quality measures. We all can support this if we have open communications, if we have systems in place where the barriers are reduced for sharing information, getting the information back. Does it really matter who gave the vaccination, or is our goal making sure that the patient gets vaccinated? And so if we have that in mind, then I think we can get a longer way. The other thing that we shouldn't allow happen is that we shouldn't allow the slowness in building technology or innovations keep us from progressing. And so we are working on some solutions, electronic solutions, to overcome some of the documentation barriers, but we know we're not there yet. So we're doing some steps to get there, but we want to continue to progress in building the relationships with all of the immunization stakeholders. Again, collaboration is important, and we need to address some of the barriers and some of the battles, I'll call it, that are happening on the state level that are keeping vaccines from being administered into patients' arms. And so we've got access points. How do we best use those access points to get people vaccinated? And then payment with ACA, everybody's hoping that's going to be a solution, but we do have some challenges there, and I'll mention a few of those a little later. So pharmacy brings a unique perspective in the touch points that it has to the public. The general public sees the marketing, sees the communications, sees the messages on the billboards of pharmacies advocating the importance of immunizations. And then those individuals that actually come into the pharmacy are considered customers. We have another opportunity to educate them about the importance of immunizations. And then those who actually get care from the pharmacist, who receive a prescription or get other services, those are another touch point that we can advocate and work with those patients in coaching them about the importance of immunizations. This slide, actually, I didn't find this, but I thank Bruce Gillen for finding this for me, but this was actually from a pharmacy publication from the 1950s, and it goes back to polio. And look at the ad and what it says. Why didn't we listen? We have an effective polio vaccine that only is effective when used. We have the same situation today. We've got good vaccines, we've got access points. Now we need collaboration focused on improving public health to get there. Let's talk a little about the education that pharmacists go through. As I mentioned, we have a nationally recognized 20-hour certificate training program, but that's just one part of the education that we provide to pharmacists. We also provide year-round continuing education programs. We also have embraced the philosophy that it's not just the practitioner that we're educating. We start early in the careers of pharmacists. When they're students, we train them on the importance of immunizations, and I'll share with you a project that we've been doing for almost 20 years now with student pharmacists to get them engaged in the importance of immunizations. But we believe that if you get them started early in their careers, that will carry forth when they become practitioners. We also provide biweekly immunization listservs, as well as we have an e-community for immunizing pharmacists to network, ask questions, talk about cases, talk about it in situations, to share with each other their experiences and best practices. And then after each of these ACIP meetings, we have Dr. Stephen Foster, who's our liaison to ACIP, who hosts a webinar for pharmacists about the recommendations and the discussions that come out of the ACIP. So we're trying to do our best to make sure that pharmacists are kept up to date with the current information that's available. Talk about the certificate training program a little further. It's 20 hours, 12 hours 8 hours live, and it covers the gamut of issues. Again, this is to cover across the lifespan, to give them the information about vaccine-preventable diseases, immunology, how do you become an immunization advocate, how do you establish a practice, how do you collaborate with other healthcare professionals, how do you deal with adverse events following a vaccination and emergency preparedness, the vaccine technique, they actually have to inject vaccine, actually normal saline, into each other, and not just one time, 3 times, to make sure that they are doing it proficiently, and also to get experience. And so included with that is also the requirement that they also have, as part of their regulations in the states, that they're up to date on their CPR certification, and many states also have additional continuing education each year to put that in place. When we developed the education program, we developed it around a set of guidelines that we adopted for pharmacy-based immunizations. And it was developed in 1996, and back then John Grabenstein was the co-author of this, and we put this together, and in 2012 we reviewed it again to make sure it was still appropriate and timely, and it was. But the 5 areas of the guidelines deal with prevention, making sure that we're advocating to our patients, partnership, that we are partnering with other immunization stakeholders and collaborating with those stakeholders in the community, quality of making sure that pharmacists are kept up to date on information, documentation, try to document in systems, giving the patient documentation, collaborating with the practitioners if they've been identified by a patient, if they have a primary care provider, getting that documentation back to that provider, as well as working with the patient. Again, we want to coach the patient. It's ultimately their decision on where they want to get vaccinated. Our goal is to make sure that we encourage them to get vaccinated, whether they get it in the pharmacy or they go back to their physician to get it vaccinated. And we've heard lots of stories where patients have come back to their physician's office because they saw a message in the pharmacy about the importance of getting vaccinated. Currently, NVAC is working on the draft adult immunization standards. In September, they'll be considering it for a vote. But looking at those adult standards, I've taken a look at it and looked at it in comparison to the standards that we have for pharmacy, and we feel very comfortable that with our guidelines and these new proposed standards that we will more than satisfactorily meet these standards. But the uniqueness of these standards draft that are out there right now is that it's not only addressing practitioners who actually administer vaccines, but those who don't. There's a role and responsibility for practitioners who don't do the vaccinations themselves to refer that patient to somebody who will. And how do you set up that referral? So the draft standards do try to address some of those and identify a role for those who do provide vaccinations and those who don't. And I'll be sharing with you a couple examples where we have pharmacists who have incorporated immunization activities in other chronic disease state management activities. Pharmacists who are doing immunizations do it in the same procedure that nurses and physician assistants do immunizations today, via a protocol or a prescription, depending upon what the state requirements are. And there are several elements of that protocol. Those protocols identify who it is that's authorizing delegating the activity, the pharmacist who it's delegated to, the types of vaccines, the procedures to follow, including when to refer a patient, identifying emergency procedure situations, and record keeping and documentation. When we survey our pharmacists and ask them, where are you getting your protocols from? Who is signing your protocol? You can see in this slide it's across the gamut in terms of the type of physicians or situations that pharmacists are doing these activities in. So you can see it's a variety of different physicians, public health departments, and so on. Pharmacists also can identify patients who need vaccinations through their medication records. And so those little auxiliary labels that you see on prescription vials aren't just there to look pretty, but they're also a way of disseminating a message to the patient. So based upon the records that a pharmacy has, which includes prescription medications, the age of a patient, we could identify and target messages to those individuals. Let's spend a little time looking at state laws and regulations. Those govern in terms of what pharmacists can or can't do. They either state it has to be a prescription, a protocol put in place. That protocol could be with a local physician, it could be with a health department medical officer, or the authority could come from the statute. Those authorities also address which antigens a pharmacist could give, the patient age, and the process a pharmacist may need to follow. And then we also have the caveat that in an emergency or a pandemic situation, a governor can sign a declaration that may expand authority. So I've done a couple of slides to show you. We try to track the authority across the states. And this is a never-ending battle because it's changing continuously. As a matter of fact, these slides are a little different than what's in your packet because as I was sitting here, my staff just got an update. And so I try to build them into the slides. But you can see the variety that we have to deal with from dealing with one state to the other. You've got 44 states that allow pharmacists to administer any vaccine, but some of those situations require a protocol, a prescription, or some other process to be put in place. And so you can see here the variety across the states. If you look at the process that a pharmacist has to follow, do they need to follow a protocol? Is it by a prescription? You can see that varies as well, where in some states it's just following a protocol. One state, they can only do it by a prescription. In some other states, it's either by a protocol or prescription, depending upon the age of the patient or the type of antigen. And then we have some states where it's either the authority is coming from the state law, it's coming from the public health department, or the statute says it's in accordance with the CDC ACIP guidelines. And so those are all built into this, and you can see the variety. So that's why it's a little difficult when somebody wants information about the authority of a pharmacist. You have to say, well, what state, and let's look into it. When you look at the age of a patient, you can see that also varies. You've got 21 states where it's no limit, it's any age, but then depending upon the state or depending upon the antigen that we're talking about, the age that a patient can get vaccinated by a pharmacist may vary. Let's look at some specific antigens. In pneumococcal, we've got 51 states that currently allow pharmacists to administer pneumococcal vaccine. When we look at zoster, all of the states allow pharmacists to administer zoster vaccines, but you'll also see in the slide there are a number of asterisks. Again, those particular states have some kind of nuance that requires the pharmacist to get a prescription or some kind of patient-specific protocol. When you look at the growth in the administration of vaccine by pharmacists to adults, and this is looking at the influenza vaccination as reported out at the recent summit, you can see the growth in the percentage of vaccines that are delivered by pharmacists. So it's between 18 to 20% depending upon what age group you're looking at. Another piece of data that CDC has put together, you can see again when you look at the type of patients that pharmacists are administering, majority of the patients are adult patients. And then when you look at, we've been asking the question over the last several years, who refers patients to you for vaccinations? You can see the primary refers of patients to pharmacists are physicians, and then it varies across the board in terms of nurses, public health departments, or other coalitions or immunization stakeholders. One of the things, too, that we wanted to make sure we were doing in pharmacy is we wanted to make sure that our members, our profession, was walking the walk. And so our House of Delegates, dating back to 2007, passed a resolution in its House in terms of calling on pharmacists to get themselves immunized, to serve as an example to patients. Well, in 2011, we strengthened that policy and put it as a condition of employment, training, or volunteering within an organization that pharmacists are up to date on their annual influenza vaccination. In some preliminary results that were released at the summit by CDC, their survey was showing 88.4% of pharmacists had received an immunization. And that's very similar to the same numbers that we were getting in our surveys that range between 85 and 86%. So we feel pretty good about that number, and we want to get it as close to 100% as we can, and we'll continue to work on that. But as I talked about earlier, we also engage our student pharmacists in getting involved in immunizations early. So in 1997, we actually launched a competition between our schools of pharmacy where go out to their communities and collaborate with public health, with other healthcare professionals, with other healthcare students to promote immunizations and to facilitate clinics being set up in their communities. And so over this period of time, we've been able to gather that we've had over 1 million individuals who have received immunizations through this project, and each chapter that participates gets recognized, but in particular we have 1 national winner and 8 regional winners that are awarded. Again, this is to get those students engaged in immunization, the importance of immunization early in their career, and carry it forth as they become practitioners. Another example of how pharmacists are integrating immunizations into their practice. In this one case, and we've got many more examples like this, this is a project where pharmacists worked with patients with diabetes. It was called the Diabetes 10-City Challenge. And these were practitioners in the community working with patients who were trying to manage their diabetes. And one of the elements of that management was looking at their flu vaccination rate. So you can see when we started out, it was in the 30%. When 3 years later, that number went up to the number you see here, which is the 65%. So you can see the growth that occurred in there. That's coaching. That's coaching that practitioner spends time. One of our challenges, as all of us as healthcare practitioners, is how do we integrate immunizations into your already busy practice that you have to go through. Immunizations is just one of the things we're asking providers to focus on. So what good examples do we have? This is one example that we like to share that shows that pharmacists are another advocate for immunizations that can help patients manage chronic disease as well as get preventive services. But we're not doing that in a vacuum. We're doing that as part of the healthcare team. In that diabetes example, those pharmacists are part of that patient's diabetes care team. So they're working with the diabetes educator, they're working with the endocrinologist, they're working with the nurse practitioner, all working together for that same cause. Here's an example of Tdap in California, where this clinic was managed by pharmacists. It was authorized by a physician in that system, but all the activities were done by pharmacists. Again, this was focused on the caregivers around that newborn patient. When we look at Tdap, this shows you the authority of Tdap. 47 states allow pharmacists, again, to administer Tdap, but look at the number of asterisks again. Depends upon the age of the patient and the situation that the state has currently. So you can see it varies, but we've got 47 opportunities to focus on increasing Tdap immunization rates. Here's another example of how pharmacists are using their database to follow up that immunization message. This one here, the pharmacist worked on a Tamiflu outreach program where he actually looked at the previous year, patients who got this medication, and did an outreach to them to talk to them. Well, you know, there's a good way of you avoiding getting influenza this year if you get yourself vaccinated. And so he had a 75% success rate in converting those patients to getting immunized. Another example that we are advocating and putting out there, we all know the challenges of HPV and completion of the 3-dose series. Well, we believe pharmacy has a solution to work with the health system on. The pharmacist doesn't need to do the initial evaluation, although they could. They don't need to do it. The physician could do that and administer the first dose. Then the pharmacist could follow up and make sure the patient completes the other 2 doses in that series. HPV is just one example. There are other vaccines where they could do this as well. But again, getting that patient, making it convenient for them to complete a series is our ultimate goal, and we think we have a solution that we'd like to work with others on to make it happen. When we look at the HPV authority, this one gets a little more complicated when you look at the state law, and you see a lot of asterisks, you see a lot of letters in this one, because it does vary by the age of the patient. It varies by, does it need a protocol, or can you do it by a prescription? And then we've got some regulations that are changing. In these slides that I'm showing you today, while a law may be passed, we don't count it as being a state that has the authority until the rule has been promulgated, which ultimately then the pharmacists can then administer the vaccine. When you look at the HPV, you see the variation by ages again. This is a challenge when you go out and try to educate the public about the vaccine. You can't just do a nationwide campaign. It's got to be a state-specific campaign based upon the limitations. Let's talk another role that pharmacists are entering into. And they've been doing it for a number of years now in many communities. And the reason why pharmacists have gotten involved in this area is because there's an unmet need. We're seeing the increase in travel by individuals, where in 1990 it was estimated international tourists were 457 million. 2009 it was 880 million, and it's estimated to reach 1.6 billion individuals by 2020, with an increasing number of those individuals going to developing countries. So those are individuals who are looking for making sure that they're protected when they go to these areas. And pharmacists have been working with their public health departments in some situations, working with other providers in their community of increasing access to travel-related health activities. And the way the pharmacists who are doing this, they're doing it under a protocol. When it comes to immunizations, it's a protocol like they're doing other immunizations. They do get the education that is required, and that they are following the guidelines that are out there. Now, this is a practice in development, so as we keep on getting more experience, there will be new innovations that are put in place. But a lot of these pharmacies are using the same tools that other healthcare practitioners who are serving people who are traveling. So those computerized systems, those screening applications, pharmacies are using those. And where there's a medication that's identified as needed, they're referring that over to their protocol physician or the patient's physician, if they have one that's been identified, to go ahead and evaluate it and to order the prescriptions for that patient. So it's not being done in a vacuum, it's being done in a coordinated way. But again, one of the challenges, and if those of you who travel internationally have found, is how do you access some of the limited clinics that are there? And so there's a need in the community. And it's not just vaccinations that pharmacies are providing this service around. They're also talking to the patients about other travel risks to look for. And so it's a comprehensive piece of information that is being provided by the pharmacist as a service to the patient. We've been working with ASTO on trying to identify some of the barriers that pharmacists and other healthcare practitioners are facing in increasing their immunization activities and increasing access to the public. And a working group that ASTO put together identified 3 buckets that need to be addressed: communication and collaboration, data set and the minimum data set and registries, as well as payment and compensation. One of the things that we've been encouraging our pharmacists to do when they have that interaction with the patient is when they're giving them their flu vaccination, are there other vaccines that the patient may need? And so this is just one example that Walgreens has put together and has been effective in when they're working with that patient of finding out other vaccines that patient may need. And so they've got different survey forms that the patient completes while they're there that help them identify other vaccines. So that then the patient has the opportunity to either get the vaccine from that pharmacy if it's allowed in that state, or to take this back to their physician to get the vaccine done. Today we have immunization record cards and forms that the patient has. That's a minimum type of documentation that providers provide. But we also have electronic solutions that we're working on. A company called SureScript, that's a data exchange company of connecting pharmacy claims with medical systems, has been working on connecting the immunization records back to the physician's office. So right now, as I talked about earlier, we're in progression. We're in implementation stages. And so they have in their system an electronic system that the physician can get the information electronically, they can get it through a secure fax, or they can get it by the mail. So we are trying to send documentation back to that medical home or the physician's practice or the clinic or wherever the patient wants to have that information sent to. But the future for all this is really two-way access to electronic health record, where the pharmacy or any other immunization provider can have access to that electronic health record to enter the information and to look at what the patient has already received. Also trying to work on getting that same type of access, that seamless access, with the immunization registry. That's another issue with a lot of different complications involved in that, but we are working on trying to come up with solutions. So let's talk about immunization registries for a few moments. Some of the challenges we have with working with immunization registries is that the agreement must be signed between the pharmacy and the registry. So there needs to be, each state has their own type of agreement, and in some situations you can't sign it as a corporation, you have to sign it as an individual practice. So those become some barriers. Doesn't mean we can't overcome them, it just means it will take more time for these activities to be put in place. Some states require reporting to the registry, and some allow global corporate agreements. We also have variability in data requirement. We have some localities that require the mother's maiden name. How many practitioners do you know collect that information in their database today? That's a barrier. We also know from our practitioners and working with other health professions, because of privacy considerations, practitioner access of the registry, so getting information out of the registries can sometimes be a burden in terms of the number of steps somebody has to go through to get that information. Patient consent requirements vary by states. So SureScript has been working with the registries to come up with solutions, electronic solutions, to make it seamless for the practitioner. And so they've actually, out of the 61 immunization registries, they're actually actively working with 36 of them. That they're also having discussions with the other ones. But what they have found so far in working with them is that a third of them have not currently moved to the new HL7 meaningful use standards. And so that's something that they're still working on and putting in place. They've also found that when there are errors that occur, that there's not an automatic notice in some of the registries. So there needs to be an intermediary who does collect those error feedback to then work with the practitioner to get the information correct. So SureScript is coming up with an electronic solution, and just to give you a little more background on SureScript, they've been working with electronic health records and physician e-prescribing for a number of years and facilitated that communication. And so now they've incorporated this next phase of working in the immunization arena to get that data seamlessly interchanged between providers. Ultimately, all of our goal is that if a practitioner could go into an electronic health record and not have to enter two different systems, one in the electronic health record and one in the registry, that's what we want to see happen. Now let's talk a few minutes about ACA and the impact of compensation. From a pharmacist perspective, one of our other challenges, while we talk in ACA about first dollar coverage for vaccines, there's a little asterisk on that as well. Depends. The depends is the provider who the patient is trying to get that service from recognized as an in-network provider? And it's not just pharmacy that deals with this. Public health departments are also dealing with this issue as well. So it's a multiple profession faceted information. Specialists are also having some of those issues as well. So we have to try to address that in terms of in-network provider status, and we believe that the newly adopted adult immunization standards will help facilitate some of those. The other challenges we have is the great recommendation that ACIP put together for patients with diabetes needing to get their hepatitis B vaccination. We have today barriers being put up that pharmacy providers cannot bill for providing hepatitis B vaccination. Even though the state law allows them to, they cannot bill Medicare for that. They're not recognized as a provider in that. And that's a nuance there that we've been trying to work through with CMS, and we continue to work on that, but that's a barrier. You've got a recommendation, you've got a federal agency that says a provider can't do that, who can help increase those immunization rates. And then the other challenge we have in payment is the variability between the Part D like dog plans that are causing frustration among pharmacy providers as well as medical providers and others in terms of the variability that some of these plans are providing immunization services and the type of administration fees that they're paying. So ultimately our goal is that every patient encounter needs to focus on education and advancing the immunization status. We are committed to that, and ultimately why we do it, why I do it, and why a lot of my colleagues in this room are doing it is to protect those that we love in our communities that we endear. And I'm done.
Thank you very much. Open it up to any questions or comments. Dr. Cohen-Wiesner.
Thank you so much for that presentation. I agree that the pharmacists have an incredibly important role in vaccines, and glad to also see that there's some plans to also handle HPV. The one thing I wonder about is often when I go to pick up my prescriptions or even vaccines when I travel to other countries, the person who gives me who gives me my prescriptions is not necessarily the pharmacist. And I've had some encounters, particularly with travel vaccines, where the person couldn't give me advice because they didn't know enough about the actual vaccines. And so I'm wondering, in the whole schema, we don't really generally have contact with the pharmacist. How can we help the people who are there plans to actually help those individuals who are actually giving you your prescriptions at the window or at the actual cash register?
Thank you. Good question. I know Dr. Foster wants to weigh in, and then I've got a response too.
Steve Foster, his representative. That is a frustration that we have in the field of pharmacy altogether. What has happened now is that patients tend to go to pharmacies where they can get their $4 prescription. So they're actually shopping for price. They're not really looking for service or quality. You can find a pharmacy that will actually talk to the patients. It's out there. But in many cases, some of these places that really do offer these super prices, you're not going to get the service that you do for that. So it's a very frustrating part for us. By law, pharmacists do not have to counsel patients on every prescription they pick up. I think that's a mistake too. But that's just a fact of life. I think as I look at things, pharmacy services has actually changed a lot over the years. And you know, people sometimes say, well, why are you expanding your practice? Actually, our practice has been shrinking. Back when I was a kid, the pharmacist could take and refill medications without a physician's prescription at that point. Things that have happened over the time. When I was in the public health service, Indian Health Service, I was a pharmacist practitioner. I had full prescriptive authority. But over time, since we've changed some of this, we've actually lost some of our privileges to do this type of thing. We never had an issue with giving vaccines or injections years ago. But again, to your original question, I think that it's just, I'd find another pharmacy to go to.
And just to follow up on that too, one of our challenges and one of our goals is also to educate the pharmacists, but also the support staff that are working. Just like we're trying to do in the medical offices, the medical technician, trying to bring them up in terms of their education. But one of my answers would also be is ask for to talk to the pharmacist, and that's something that we as the ASAPHA are trying to educate the public. Ask the pharmacist. Know your pharmacist. Know your medicine. Get that relationship with the pharmacist. And what we have found, pharmacists who are actually administering vaccines have developed that relationship with those patients. So we encourage people to ask the pharmacist. In terms of travel, not every pharmacist at this point is educated on specifically the travel vaccines. Those who are getting into it are getting the extra training. We lost our chair.
I'm back. Other questions or comments? Dr. Hahn.
Yes. This might be a question for CDC. I'm not sure. Could you address the issue of pharmacists as VFC providers? Is that allowed? What are the challenges at every level? I understand it's being discussed, and I just hope that we can discuss it here a little bit.
I'll let Dr. Shugget, and then I'll follow up on our experience.
Yeah, the pharmacists can be VFC providers. They have to sign, they have to do all the things that a VFC provider would need to do. So there's the agreement that needs to be signed. We're trying to make sure things are all in order for that, but that is allowed.
And to follow up on that, we actually work with the CDC to get a clarification to the states on that particular issue, and one of the clarifications was that pharmacists who, say for example, are in an area where there's a need for assistance in the adolescent population, they could do adolescent, but they don't necessarily have to do the childhood. So there were some interpretations that help put that in place. But that is a challenge. One of the challenges as pharmacies are facing is also getting the states to allow them to become VFC providers. Some states require you to be a Medicaid provider, but then Medicaid's not allowing them to become Medicaid providers for immunization. So there's barriers all along the line that we're trying to address.
Dr. Keitel?
Thank you very much. Can you comment on the record-keeping requirements and any issues that you've had with regard to providing people who have received vaccines in your facility with information about what they've received if there's no link to the provider? In my experience, there's been no question about a provider and where to send the information.
Okay. Well, it depends on the state in terms of what the requirements are for record keeping. But at a minimum, the pharmacy should be giving the patient the consent form. That's their documentation. Encouraged to take that next time if they have a primary care physician, to take that back or send it to their physician. We do have examples across the nation where pharmacists are sending the documentation to the physician if the one's on record. Some of the bigger players have automated systems that send it to the prescriber. In some states, they're required to submit it to the registries, and so it varies by the state in terms of the type. But we do have systems and the guidelines in place to give documentation at a minimum to the patient and then get it to the primary care provider.
But in terms of retention of records at the pharmacy, what requirement is there for maintaining those records?
It's the same legal requirements that they have for other medical records in that state. That's state-based requirement.
Dr. Sawyer?
Both public health systems and professional organizations have worked for many years now with physician providers on quality improvement in immunization delivery. I'm wondering if there are systems in place within the pharmacy organization to look at the quality of the delivery, including just the communication and documentation that Dr. Keitel just brought up, but in terms of missed opportunities and use of proven practices such as reminder recall.
Good question, Dr. Sawyer. I think we are encouraging our Science Academy to look at some of those when they look at topics to recommend to their members for research. We are looking for other research to be done in that area. We do have some studies that have shown pharmacists' ability to do that, and we have some, I'll call them proprietary, that haven't been publicly released, but we do know there are some studies that have shown improvements in some of those quality measures. That's the other point that we do advocate in terms of working with the pharmacists, is the pharmacists can help medical providers meet their quality standards and work with them to get that documentation back into that record so that they get credit for those vaccinations being done.
I'm going to take the prerogative to just hold comment for a little bit, understanding that Dr. Dushin needs to leave very shortly, and we'd like to get his presentation in. And I'm wondering if you'd be willing to stick around for a little bit. I know you're going to join us for lunch as well. Okay. I think we can keep in session for a little bit longer if there's any additional questions for pharmacy. And I think as opposed to wait until the end of the meeting, I just have a letter that's pertaining to the pharmacy discussion as well as germane to the Japanese encephalitis vaccine discussion yesterday that I'll read into the open meeting at this point in time. Because I think it may stimulate some additional comments either here or during our lunchtime meeting. So this is from Dr. Jeffrey Band, Professor of Medicine, Oakland University, and William Bowman School of Medicine in Rochester, Michigan, and also Medical Director of InterHealth, Health Care for International Travelers. Dear ACIP members, it has recently come to my attention that pharmacy chains are entering the field of providing travel medicine counseling and highly specialized vaccines without a physician order. Such counseling is performed by a pharmacist or a pharmacist aide. I feel this practice is quite dangerous to patients, must be stopped. Travel medicine counseling should be best performed in a specialized travel clinic by a person who has both the education and training necessary to provide counseling and also has clinical experience in this field. In the past, two basic models have existed for delivery of care to the international traveler. In the first, an educated and trained physician obtains the traveler's demographic and travel information, provides the health advice, and helps the traveler with decision making. The nurse then reviews vaccine adverse effects, obtains informed consent, and administers the vaccine. In the second model, the nurse practitioner, physician's assistant renders all pre-travel counseling and care under detailed protocols developed by an educated supervising physician. If questions exist, the supervising physician is always available. Protocols must exist not only for all vaccines and medications, but also for the provisions of health care to special patient populations. Likewise, a detailed protocol for managing acute allergic reactions and cardiopulmonary arrest must exist. Patients' records should then be reviewed by the supervising physician to ensure appropriate care and that all protocols are followed. Such guidelines have been established by the Infectious Disease Society of America and have been endorsed by the International Society of Travel Medicine and the American Society of Tropical Medicine and Hygiene. I'm quite opposed to a pharmacist or pharmacist aide performing the necessary medical assessment in assisting or assessing travelers' needs and providing the detailed counseling required. Likewise, I'm opposed to a pharmacist administering many specialized travel medicine vaccines without first obtaining a specific physician order. As the medical director of a travel medicine clinic, I know and understand the complexities of travel medicine. Each of our nurses must pass a 6-week orientation period before being permitted to counsel under guidance, and that's underlined. It takes at least 6 to 12 months for a healthcare nurse to fully understand the practice of travel medicine. I do not feel that a pharmacist or pharmacy aide has the training or experience to practice travel medicine. The practice of medicine must not be delegated to a pharmacist. A pharmacist is not trained or licensed to provide direct medical care to patients. I look forward to your comments, response, and guidance. It is in our patient's best interest to ensure care is provided by a licensed physician, nurse, or physician assistant, persons with years of medical training and experience in direct patient care. Sincerely yours, Dr. Jeffrey D. Band. And I see Ms. Hayes first.
Healthcare is a state-regulated industry, and so the regulation of advanced practice nurses and physician's assistants varies from state to state. In many states, they are independent practitioners and they are not supervised by physicians. They have collaborative agreements, but they are not supervised. So I think the word supervision is highly contentious in many states.
And this probably pertains to Michigan, the side of where Dr. Band is. Dr. Foster.
Actually, Mitch probably ought to make his way back up to start answering some of these questions. He's still here. The one thing that is not true in that statement is the fact that we do it without physician supervision. We have to have either prescriptions or protocols or a collaborated agreement in order to do it. That's state law. Every state requires that. So it's not something that they do without a physician approval, nor is it without a physician referral if we need it for that. Now, again, I'm not a travel vaccine person and I don't do it. We do have several on our National Advisory Committee, and they are actually members and certified through the travel societies to administer, or certified through the societies as certified travel specialists too.
Thank you. Dr. Grog.
Yeah, I have mixed emotions. I have a certificate in travel medicine by the International Society of Travel Medicine. And when I first heard they were doing travel consultations, I was concerned. But they're not really doing that much in the way of travel consultations that you can't get from the CDC travel website. And if you look at health departments that administer travel medicine vaccines, there's no consultation, and they don't even write for medications for malaria prophylaxis. So, let's watch and see what happens in the future.
Can I also add one other point of clarification that's a misinformation in the letter, is that pharmacist aides do not do the service. They may give the patient a form to complete, but all the clinical interaction occurs with the pharmacist.
Thank you for that clarification. Dr. Freyhofer.
Sandra Freyhofer, representing the American College of Physicians and the American Medical Association. I support many of the concerns, or our organization support many of the concerns expressed in that letter. I do travel consultations in my office, and as the patient's primary care physician, I have knowledge of their diseases, and it's not as easy as it may sound. It's fairly complicated, and I think it involves a lot of consultation and discussion with the patients about their risks or activities, and I think it's concerning that if other people than those taking care of patients are providing this service, because when they get back from their trip, if they weren't properly protected, I'm going to have to pick up the pieces and would like to make sure that they're protected when they do international travel.
If I can add something, a comment. The tool that pharmacies are using is the same tool that the travel health clinics and practitioners are using. So those questions are being completed with the patient and then reviewed, and where appropriate, the patient is referred either to their own practitioner if they have one, or one that the pharmacy has identified as that expert to refer the patient to.
Dr. Sawyer, Dr. Grogg, and then Dr. Harrison.
So we've just heard a detailed description of the rising role of pharmacists in giving routine vaccination and the training that they undergo. I'm not aware of any increase in errors in vaccine administration that are attributable to this practice. I'm hoping we have data systems in place that can track that and make that a clear scientific-based conclusion through the VAERS system or others. But I think that the experience to date would support the role of pharmacists in giving all vaccines.
Dr. Grogg?
Yeah, mine was more of a clarification. CDC does the yellow fever sites, so you have to have CDC approval. So pharmacies are not doing yellow fever, I believe.
In some states they are. They go through the same CDC training as any other healthcare provider who does do that. And some states do allow them to get a yellow card.
Okay.
I have Dr. Harrison.
I was going to ask, are there any successful models that are already out there where this is working well? Highly active pharmacies in the travel vaccine?
Yes, we have a number of practices and a number of chains who are doing an excellent job. We have smaller practices, some that are university-based, like in Dr. Sawyer's state, we've got University of Southern California, where that clinic is run by a pharmacist. We also have Safeway that has some practices. We've got in Virginia a pharmacy regional small chain that's called UCROPS, well, it's now called Martin's, but they've been doing it for a number of years, all based on a community need that came to them, that they had people who were traveling that needed that service and couldn't access it.
I'm going to cap discussion at 3 more. I have Dr. Lair, Dr. Sun, I know you had a question earlier, and then Dr. Feuerhofer. So Dr. Lair?
So Jamie Lair, AAFP. How many student pharmacists are coming through their training with this vaccine certification? Is this common? Is this uncommon?
We graduate between 12 and 14,000 pharmacy students a year, and I would say almost all of them have gone through the training.
And Dr. Sun?
Thank you. I just want some clarification on, you had said in your slides that the pharmacists are trained to document adverse reactions, and would you just clarify on what would be how would that happen in the case of an adverse event from vaccination?
They're trained like any other healthcare practitioner who's gone through either the CDC program or their own program. A component of the program talks about VAERS reporting and managing situations, and so it's part of the training and information that they get is how do you use the system and what's the system all about.
Just one follow-up. So if an adverse event occurs and the patient has a primary care doctor, who does the reporting? Does the pharmacist report it, or would it be referred to the primary care physician?
It depends on the situation. The ones that I'm aware of, and they're rare, is it's been a dialogue between the pharmacist and the physician on who submits the VAERS report. And I think the VAERS folks will probably tell you more about how that gets reported.
Dr. Feuerhofer.
I wanted to make one further clarification. Dr. Sandra Freihofer, representing the American College of Physicians and the American Medical Association. It's one thing to administer a vaccine if given a prescription. It's another to be doing these travel consultations. Again, when these patients get back from their trip, if they have problems, are they going to go to their pharmacist with their problems? I don't think so. So this should be done under a physician's guidance.
Thank you. I think at this point in time, and keeping an eye on the time, we will break until starting up with the influenza session directly at 1 p.m. Thank you.